phone capacity?
I hear you.
Wonderful. Thank you very much. This afternoon, we're going to conclude our discussion of child and adolescent psychopharmacology. We're right on schedule. Look at the slide number, it's about right. And we're going to talk about cultural issues, non-traditional treatments, newer medications, newer research on newer approaches with medications, some of which is kind of cool. We're going to go through medical disorders, Tourette's, substance use disorders, which I'm a big fan of that topic because of that overlap between mental health and substance use disorders. But first, let's go with psychotropics for personality traits. Well, I want to...
Could I ask you a question?
Please.
The next class that you have is the December class. There's no subject matter there. Can you tell me what that's going to be on?
Well, that's interesting. I don't know the answer. My next class in teaching, and I think it's not with you folks, but the next cohort is in April on ethical and legal issues in psychopharmacology. So you'll have to check with Judy Steinman about this so-called December class without a topic. It has nothing to do with me. Does that make sense?
Yes. Somebody else is putting on the chat, this is our last class. That weekend is a makeup if needed with Dr. Strada.
Okay.
It's a Q&A with you.
Not with me. I'm Dr. Brady.
Oh, Dr. Brady, I'm so sorry. I'm so sorry.
Sorry I interrupt, Doctor. It's just because I was also addressing another cohort on the exact same question about the next class with Dr. Strada, which is supposed to be a question, the Q&A session regarding his class and the exam before, I mean, in a sense, the review session before the exam, which is the next day on December 8th. I haven't heard yet from Dr. Estrada. I'm gonna be a little more persuasive through Dr. Steinman and myself to see if I get that. That's why I haven't yet updated any substance, any material into that session. I haven't got anything back yet, or hour being set yet. That's why I don't even put a Zoom link there yet, because I don't know when exactly it's gonna be our session. Sorry for interrupting.
No, not at all. I'm glad you clarified. I didn't realize that I was going to be your official last class in your whole master's program. That's pretty cool. I feel quite honored to have this spot, and I hope it proves to be worth your while. All right, now let's shift to personality traits. Why on God's green earth would you ever want to use, Dr. Brady asked rhetorically, mental health medications for personality traits? It sounds on the surface that it's overkill and possibly harmful and all the rest. Well, I will give you a little bit of that. There is a kernel of truth to that. One of the ways I think of personality disorders and medications is the final, and I think I made this one up. I think this is my invention, but I could have stolen it from somebody else, and I would acknowledge if anybody would come forward. But one of the ways I think about medication use with personality traits and disorders is you have an individual on the edge of a cliff holding on by their fingernails from dropping into the cavern below and instant death. And what you're asking this person who is using all of their defenses, maladaptive and primitive as they may be, directing them toward one or another of the personality traits or disorders, they're holding on by their fingernails. They're holding on for dear life. They're going, one with a borderline personality organization who can go into brief psychotic episodes with supreme stress, etc., is holding on for dear life. And what are you asking them to do? You're asking them to take one of their hands off that cliff and their fingernails and reach for the medication. And trust that that medication is going to help them get off the cliff in a safe way and up and safe. I have to tell you that I have numerous examples in my patient load over the years of people, particularly with adults with personality disorders and severe personality disorders that have tenuous holds on reality and stability. And I'm offering them a medication which in theory should help them calm down their high reactivity, emotional lability extremes, impulsivity, self-mutilation, etc., when I'm altering their self-perception of who they are. And at some core level with personality traits and disorders, there is a emptiness, in my opinion, that is filled with primitive defenses, a search for identity, an unstable identity, and an unstable emotional life. And it's very troublesome to have them take a medication, because my second best teacher in my career after my brother Bob was this long-term patient with her diagnosis of schizoaffective disorder and severe borderline personality disorder. She'd flip in and out of psychosis at a drop of a hat. And any medication I gave her, or people similar to her that were less intense, would disorganize them psychologically, such that any possible benefit of the medication was removed or made worse by an altered psychological state. It's as though she were saying to me, I can barely hold on to who I am and how I can get through life, and you're handing me a medication that is making me feel different. Anything that makes me feel different, I decompensate with, because it's unfamiliar to me and scary. So I caution you about the use of mental health medications for such folks, whether they're teenagers or adults. That being said, I think they can be helpful. And have I seen more help? Yes, I've seen more help with more patients, but it's not as good as a benefit versus risk analysis than if someone did not have personality traits or personality disorder, because of that very easy propensity to decompensate. Does that make sense? I hope it does. All right. Having said that, mental health medications are used all the time with people with personality traits, particularly cluster B, particularly borderline personality disorder or borderline traits. Also narcissistic traits and personality. These folks become depressed, sometimes suicidal in their depressions, histrionic, overly emotional, overly reactive. And if you can notch down that emotional reactivity with the use of judicious use of psychotropic medication, it could be quite helpful. Frankly, I haven't seen very much benefit with medication for folks with antisocial or sociopathic tendencies or personality disorder. However, these folks often find themselves depressed, anxious, and unhappy because things aren't going their way. And I have used a more cognitive behavioral approach, frankly, with narcissists and sociopaths, appealing to their egos, if you will, saying, well, that didn't work so well. What other things might you try? Well, that, interaction you had in your antisocial sociopathic way seemed to be a real turnoff to the other person, your partner, your parents, your workmates, etc. Let's get smart about this. And are there things that you could do, even in a play acting way, that could have the outcome be more positive and not so negative? That's the kind of practical bread and butter approach I've used with people who they don't come in for their personality traits or disorders. They come in because they have an acute episode of depression or a panic attack. Things aren't going the way I wanted them to. I've pulled out all the stops and done everything I can, and it's being thrown back in my face, and it's not working. I'm miserable, I'm suicidal, I'm depressed. And you kind of you grab onto that because it's a bit ego dystonic. One of the characteristics, of course, of personality traits and disorders is that they tend to be ego syntonic, not too insightful about themselves, and benefiting from some emotional distance, if you will, being able to look at the situation. Well, that didn't go so well. Maybe, what if is there another way you could have tried it that you could have been more successful, rather than cursing out your boss or throwing a hissy fit with your teacher, etc. Very practical approaches. All right. But you might be tempted, and it would be certainly used a lot, to consider medication that might help the emotional lability, high reactivity, impulsivity, self-mutilation, splitting, and even substance abuse. So heading to slide 157, we have our standard retinue that we have used for many others. We have the SSRIs, we have the mood stabilizers, we have the atypical antipsychotics, we have the opiate antagonists such as naltrexone, and we have the sympathetic nervous system decreasers, flight, fight, and fear, such as the beta blockers and alpha agonists. Why would you use one over the other? Okay, for delicate cutting, naltrexone is an excellent way to make it hurt the next time it hurts. When you delicately cut on yourself, you don't feel that dopamine rush of, oh, I feel alive because I can see the dripping blood. I feel connected in ways that I didn't feel connected before. I feel soothed. Does it hurt? No, it's just numb, if anything else. Naltrexone is wonderful for that. Damn it, doctor, it hurts when I cut on myself. And you smile with them and you say, yeah, so let's work on other coping skills and other ways to deal with your emotions than this quick fix of the dopamine rush of delicate cutting. All right. The atypical antipsychotics. If the cluster B disorder bridges on brief psychotic episodes or semi-psychotic episodes, a low-dose atypical antipsychotic may be of some help in taking the edge off and thickening your psychological skin, if you will. Mood stabilizers, if you are too moody, if you're too flighty, if your emotions run too extreme, high and low, mood stabilizers, especially the anti-seizure medications, Tegretol, Depakote, Valproate, Topamax, etc., Lamictal, could be helpful in taking the edge off, not removing the problem, but taking the edge off so that they can make use of talking therapy, milieu therapy techniques to make progress with their mood disorders, their personality disorders and traits. And one of the goals of treatment for people with personality disorders is to help them develop insight into their processes and be able to say to themselves, there I go, I'm heading down this negative path, I need to stop it. The doc and I talked about this, and here's what I need to do to my relaxation skills, my diversion skills, etc. But it may be too extreme emotionally that you'd want to add in a medication judiciously to take the edge off. Same for the beta blockers. If you're always being stimulated in your sympathetic nervous system on the edge or flight or fight, that's really exhausting. And it's also kind of addictive too, compelling. And if you can knock it out a bit, so there's a greater degree of less fear, less fright, less fight, etc., then you've helped the person. Now, just because someone has a borderline personality disorder or traits doesn't mean they're protected against psychotic, schizophrenia, like my patient, schizoaffective and borderline. By the way, she claimed that she had been sexually abused as a child by her mother. Very unusual, right? The old rule of thumb is if a woman sexually abuses a child, by definition, the woman is psychotic. My patient was psychotic. In all likelihood, her mother was psychotic, and the sexual abuse occurred in that context. I don't know if it was true or not. She used to press me on it. You don't believe me. It was a great lesson for me. Yes, I believe you because you believe it. Does that mean it occurred? I don't know. But I believe it because you believe it. And that's what we have to go with, that yes, it occurred. Did it actually occur, or was it your fantasy, your imagination, your psychosis talking? I don't know. I wasn't there. I don't know your mother. I don't know the situation. Everything you described tells me that you came by this honestly, but let's go with that it happened. That's how I deal with that sort of stuff. Doctor, you don't believe me. I can't work with you unless you believe me, and I know you believe me. Okay, I believe you. You're just saying that. Well, in part I am saying that, but in part I mean it too. But I wasn't there. I wasn't a fly on the wall. There's no camera. There's no verification. Let's not go down that road. You say it happened. You felt that it happened. Let's go with that. I border a bit in some dangerous territory of the phenomenon that occurred 20, 25 years ago with repressed memory syndrome of people coming to a therapist and saying, I have muscle memory in a way of being sexually abused pre-verbally, and I have no way to articulate it or understand it. Would you help me develop it? And boy, we did some really wickedly bad work. I did not, but some of my colleagues did, of helping to build multiple personality disorders, even charting in a pie chart. One of my mentors did pie charts with his patients of this part of the pie was personality 1 and this was personality 2. And I just thought intuitively at the time, this is scary stuff, and it's pathologizing and giving credence and a story to what may be nonsense and not true memory, but a search for meaning, a search for identity, and a search for victimhood and blame, etc., that would take people down a very bad path. I think it was connected to the McMartin preschool case where these teachers, preschool teachers, were convicted of multiple child molestation of their preschool children, and it turned out to be total fantasy and bogus, and built up by the therapist who brought anatomically correct dolls in where the kid had never seen an anatomically correct doll, so to speak, and you can bet they'd be fixated on it because it's interesting and curious and seductive, and you want to please the therapist. And we as therapists have done some real damage in past years with patients in this area, and I caution good boundaries and skepticism. All right. Don't know if I told you that I treated one 10-year-old boy whose adoptive mother was an RN, and she was almost a Munchausen by proxy mother, where she would adopt these special needs kids. This kid was had cerebral palsy, I think, and was in a wheelchair, as I recall, or he had crutches, I can't remember. And by the time, within a couple of years of taking this very damaged, psychologically and physically damaged kid, she had turned him into a multiple personality disorder kid, and she was therapizing this kid herself and saving the world and curing him. And total nonsense. She was awful, but well-meaning, and on the surface, a saint. It took a while to figure that one out and try to reverse the damage. Okay, I digress a little bit. So, SSRIs, as well as the others, thicken psychological skin, as I've talked about. You can fake it better. You can be a better actor, be more successful. You're able to in theory, you're able to maintain your equilibrium a bit better when stressed, decrease splitting as the patient is not as reactive and anxious, and nor needing splitting as a primitive defense as much. Mood stabilizers simply stabilize mood and the highs and lows, so to speak. Always get family histories with these cases, of course, because you're going to find that some members of the family are depressed, others have bipolar disorders, etc., and your client, your patient, has a personality trait or a personality disorder that is informed by their family's mental health, other diagnoses. The atypical antipsychotics I mentioned, low dose, ego glue, it never worked with my seriously ill adult patient. It always discombobulated her, and she'd always be worse. I ended up using no medications, even antipsychotic medications with her. She had she had over time figured out a way to compartmentalize and not act on her psychotic thinking, and medications destabilized her every time. And we tried every medication. I wouldn't give up. She wouldn't give up. She insisted on new medication trials. I wanted to cure her, so I went along with it. It took me about 10 years to figure out we were definitely not this wasn't working out with meds, and it had to be interpersonal psychotherapy focused on transference and countertransference, psychodynamic, but also CBT focused and oriented. She was the one that I lost it once with her, and I think I started yelling at her. She came back, "How could you do that?" And I said, "I am a human being, and look, and I'm pretty good at this, right? I've never yelled at you before. I really apologize. There's no excuse for what I did, and I hope you will forgive me." After saying that, I said, let's learn from this. Boy, if you can get me to act out and lose it with you and hate you momentarily, you are one powerful person. congratulations. And she'd smile and she'd say, yeah, I really pulled it off, didn't I? We could laugh about it later. Not at the time. The naltrexone, 12.5 to 100 milligrams for self-mutilation, counteracting that feeling that cutting makes me feel alive and in touch with myself, lessens the euphoria of self-mutilation. It hurts. Ouch. Beta blockers, decreasing emotional reactivity. Again, and this is the premise for the whole weekend, medications only make one available to the therapeutic work at hand, whether that work is therapy and what kind of therapy, such as CBT or dialectical behavior therapy, which is Marsha Lanahan, and her work with dialectical behavior therapy is one of the breakthroughs I consider in the last 30 years of working with borderlines. Before, we would just set up no suicide contracts with them, which they would violate, and then we could fire them and say in good conscience, we did our best. Well, that's nonsense. We didn't do our best. We just set it up so we could not have to work with that obnoxious patient anymore who didn't behave. Pretty ego driven by the therapist. All right. Now let's shift to addictive disorders. Very important topic, as I've discussed in different ways. You've got the alcohol-related disorders. You have the anxiolytic and sedative hypnotic, the benzos, the barbiturate dependencies. You've got the stimulant-related disorders, cocaine and methamphetamine. You've got the opioid, heroin, methadone, all the prescription opiates, Flexeril, hydrocodone, OxyContin, all of that. Then you have the opioid maintenance medications such as methadone and Suboxone that substitute one for the other, but have fewer side effects and greater life functioning. Better to be on methadone for 20 or 30 years than to be on heroin for 20 or 30 years. Although there's drawbacks, but there's definite benefits. Tobacco-related disorders, and the new scourge we're hearing about of the epidemic, if you will, of middle school kids getting into vaping flavored tobacco, such as peppermint and cherry and apple flavor and all, that is just, I was watching a documentary on this the other day, and it's like increasing 100% a year with these middle school kids, and the Juul, J-U-U-L company, and others that are addicting kids at these young ages of middle school and high school to be basically lifelong nicotine dependent, and other substance-induced disorders. Again, I urge you to develop your expertise with substance use disorders as part of your clinical psychology and perhaps psychopharmacology practices. All right, jumping into it. The alcohol-related disorders, by far the most prevalent addiction, child, adolescent, adult than others, because it's so ever-present. It's in most homes, in the liquor cabinet, etc. And it's a rite of passage and a ritual to get drunk. I remember one drunken episode when I was 16 years old as a camp counselor at a Boy Scout camp, where I just got totally schnockered on Four Roses bourbon, which is a really cheap bourbon. And to this day, more than 50 years later, I am not a fan of bourbon because of that episode. Okay. So we have alcohol sensitizing agents that make you more sensitive, and it's not pleasant. We have drugs that directly reduce alcohol consumption, that have you satisfied earlier, or you otherwise don't want more. We have agents that affect other neurotransmitters that indirectly help the alcohol-related disorders. And then there are the drugs that are often needed or used in the so-called post-withdrawal affective disturbances. We can talk about that a little bit. There's a new trend of children and adolescents drinking hand sanitizer because of the high alcohol content. Okay, alcohol sensitizing agents. And from this, I'm talking about Antabuse is the classic one, where this is in 1/4 of the Asian population, particularly Chinese. They do not have the enzyme that can metabolize the oxidation of aldehyde to acetic acid. And so these folks are left with flushing, with fast heart rate, rapid breathing, very unpleasant. And it's a natural limiting factor for such folks to drink alcohol because it makes them sick. It's really unpleasant. Well, this is what Antabuse and Temposil do. They sensitize you by inhibiting aldehyde dehydrogenase, ALDH, the enzyme that catalyzes the oxidation of aldehyde to acetic acid. So if you drink alcohol if you have the genetic predisposition, or you take Antabuse or Temposil, you will get this reaction. Your blood aldehyde level rises, and you'll have what's called a disulfiram ethanol reaction, DER. In its mild form, it causes a feeling of warmth and flushing of the skin, redness of the face, upper chest, heart rate increases, palpitation, decreased blood pressure, nausea, vomiting, shortness of breath, sweating, dizziness, blurred vision, confusion. It lasts about 30 minutes and is time limited. And that is a great behavioral way to keep from drinking, saying, I don't want to feel that way. So alcoholics who want to beat this medication will stop it. They tell me this directly. I stopped the med on Thursday night so that I could party on Saturday. It would be out of my system enough on Saturday, and Sunday I'd resume the Antabuse. So isn't that good, Doc? I only drank once this week on Saturday. Yeah, that's good. That's improvement. That's harm reduction. But could we work on this a little harder so that you didn't have to put yourself through this, and also play some mind games on fooling yourself and me? In its severe form, it could be life-threatening. You could have marked tachycardia, low blood pressure, low heart rate, cardiac arrest due to vagal stimulation associated with vomiting. You can vomit yourself to death, congestive heart failure, convulsions, and this may occur with a single drink. So, and also the reactions to Temposil tend to be more mild than to Antabuse. So I actually don't like prescribing either one of these medications. I don't like the idea of making people sick. It just kind of goes against my grain. For some people, it's a godsend, particularly for professionals that are on the verge of losing their professional licenses, whether those are lawyers, pharmacists, dentists. Dentists have one of the highest rates of alcoholism and also suicide. There's an old bad joke of, yeah, they're a dentist. But let's not go there. I've known some fine dentists who are very happy and take great pride in their professionalism and do wonderful work. And if you looked in my mouth, you'd agree with my dentist. All right. But if you're on the line and you have a drink, you're an airline pilot or something, and you have a drink, and it could jeopardize your job, jeopardize people, you want to use some big guns. And these are the big guns, Antabuse and Temposil. All right. Psychotropics that directly reduce alcohol consumption. So we're talking about the Revia, the Vivitrol, the opiate receptor antagonists, where you're not going to get a buzz for that first drink. And you're saying, ugh, this feels like that second or third drink where I feel sort of logy and creepy and tired and have a headache and a stomach ache. And I think I'm not going to drink anymore. Well, this occurs with that first drink. You don't get that first party high, life of the party, social butterfly type feeling you do in the cocktail party where the first martinis come out, the first one. Everybody's laughing and giggling and blah, 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 right? It knocks that out. And so it will limit. It's like, why would I drink? It doesn't do anything for me. It just makes me feel kind of yucky, which is the effect it would have after normally for 2 or 3 drinks. Then you can use a catecholamine receptor like bromocriptine. I've used that once with one patient who talked me into it. It's a hassle. I don't like it, but it's there. This is a very smart guy who researched everything and come to me saying, here's what I want and here's why I want it. And I'd go along with it for the most part. I learned a lot from him. Nothing seemed to work that much. And I was pretty unfamiliar with some of these outlier medications, and that made me uncomfortable to begin with to prescribe them. I had to keep close rein on this guy in terms of watching for any problems or side effects. Nothing ever came up, but also not much benefit from it either. I think it was a bit of a wild goose chase and a attempt to be different and do it. He was pretty narcissistic and he had to do it his way and his plan, and he had to be in charge of it. And so one of the things I worked with him is get to AA groups, and just shut up and be in the back of the room and listen and learn. And without saying it directly, don't be so highfalutin and full of yourself. You're actually your own worst enemy when you do that. But I got that impression across to him. We had a pretty tight relationship because I was one of the few people who could tell him off. And that was good. Challenge him. He had everyone else snowed and bullshitted. Serotonin agents, serotonin SSRIs. So there are studies that show that low levels of 5-HT can lead to aggression and readiness to ingest alcohol. So SSRIs can reduce drinking in non-depressed adolescent heavy drinkers. Isn't that amazing? You build up their serotonin levels and they're not as aggressive and interested in drinking as much. All right, moving on, question 40. Naltrexone, Revia, which is the daily one, 25 to 100 milligrams in the morning, naltrexone, or the Vivitrol, which is long-acting monthly injection, is prescribed for the treatment of alcohol dependence, and it alters the body's response to alcohol by making its ingestion unpleasant or toxic. Now that's a trick question. A little bit of a trick question. The answer is false. We're talking about Antabuse or Temposil that makes the ingestion unpleasant or toxic. It's a subtle thing, and I probably shouldn't have this in there, but it's a trick question that I just want you to think about, that Vivitrol, if you're not cutting on yourself, if you're not taking that first drink, there's no problem. Then you cut on yourself, delicate cutting, or you take that first drink. Well, if you cut on yourself, you're going to feel it, and you're going to go, ouch, that hurts when I do that. If it's that first drink, it's not that it's unpleasant or toxic, it just doesn't give you the buzz that you wanted. There's no there. So why bother? And why jeopardize your program and your sobriety and etc.? Why get your sponsor ticked off at you and dress you down for playing games, right? That's what sponsors do in a trusting, friendly but challenging manner. That's why you pick a sponsor. Okay. Psychotropics affecting other neurotransmitter systems. very legitimate medications, FDA approved, Camprol, that work on the glutamate GABA neurotransmitter receptor balance. This is an amino acid derivative. Sounds cool. It affects the GABA and the excitatory amino acid glutamate neurotransmission, and it decreases cravings. It works. But look at this. You have to take 2 tablets 3 times a day for weeks, months, or years. And it's a pain in the neck. It's a hassle. It's been around for a long time. It's not very popular because who wants to take something 3 times a day? Remember my original point that 50% of reason medications don't work is non-adherence and non-compliance. Well, try taking something 3 times a day for something that you don't even want to take. You'd only do it if you were an impaired professional and your license was on the line and you wanted every help that you could have to keep from relapsing, because that next relapse means the loss of your pilot's license, the loss of your RN license, the loss of your medical license, et cetera, your veterinary license, your dental license, anything, any profession that has access to drugs, et cetera, should be thinking about in their impaired professional program of doing everything they can do. And do you know that in these impaired professional programs, that often built into them are once a week random tox screens for alcohol or for drugs. And the computer sends you a daily thing every morning saying, "Good morning, Miss Smith. Have a good day." And then it'll say, "Good morning, Miss Smith. By 10 o'clock, I want you at the lab dropping a urine sample or doing a breathalyzer." And it's random during that week. And you don't know which day it's going to be. So you can't play games with weekend drinking or anything like that. Because if you get busted in the urine tox screen, they'll repeat it saying, okay, it could be a mistake, it could be a lab error, but if it's confirmed, you're nailed and you've just lost your license because you're already in an impaired professional program, and they take no prisoners with that. That's not true. They let you flounder a little bit, but they have a very tight leash, and the people that I've worked with that are professionals, I worked with a couple of anesthesiologists and a couple of physicians. ER doc was my last one. And they have a very short leash. And if they blow it, it's all hell to pay. How much does it cost to be part of these programs and to have random tox screens? It's like $1,000 a month just for that, to be on this random computerized tox screen system. Not to mention the thousands of dollars they've spent in lost income, in lawyer fees, and the rest. It is hell to pay. I think I've read recently that a DUI costs nowadays approximately, $50,000 for lawyer fees, for lost wages, for lost licenses, etc. It's phenomenal, a DUI. It just changes your life. Don't do it. Don't get caught. Don't drive drunk. Take a cab, take an Uber, get a friend to pick you up. Don't be stupid. Okay, moving on. Let's talk about the so-called, what the heck is this, post-withdrawal affective disturbances. This is a protracted withdrawal. What happens when you go through withdrawal is that you're left, first you go through the acute symptoms of withdrawal, mitigated and minimized by the help of things like catapress, benzos, etc., to ease the body through the withdrawal syndrome. But you're going to wind up a few days and weeks later, anxious, irritable, insomnia. You might appear depressed. Was this pre-existing? Sure it was. You self-medicated with substances, your depressive disorder, your anxiety disorder, your panic disorder, etc. But it's also related to your body going through this shock of no longer allowed to be dependent on this medication, alcohol, opiates, etc. And you're going to be somewhat anxious. Like 90% of people who go through withdrawal are going to be anxious and depressed. Their life sucks. Their life is, the life is before their very eyes. Their family, they're divorced. The wife her husband is leaving them or threatening to. The adult children have had it with you. It is really frightening for the individual. And if they're not a little anxious and depressed, there's something wrong there. Is it a protracted withdrawal? Yeah. Or is it something else? I'm not sure. I'll tell you what, though. A lot of addiction treatment facilities try to scam the insurance companies, saying in their peer-to-peer reviews, oh, the patient is in a post-withdrawal affective disturbance and they need to be in residential treatment for another 2 weeks, which, by the way, make it 28 days to meet the Minnesota Hazelton model of 28-day residential is the necessity. Well, that's kind of gone by the wayside, just as surgery is now done outpatient or shorter inpatient with then outpatient follow-up, etc. There's no hard and fast rule that requires someone to be in a out-of-home hospital or residential situation for their alcohol dependence, or in like the old days. There are some programs that are 90 days, come hell or high water, and they'll often petition the insurance company saying, my patient is unique, they're going through a post-withdrawal affective disturbance. And I say, because I've been on both sides of this, I say, well, let's talk about why they require 24/7 treatment versus why can't they be in a group home, a sober living home, or at home and continue their treatment in an outpatient setting? Why can't they return to work and do an IOP after work 3 times a week? It all depends on severity of symptoms, severity of addiction, and what is medically necessary. So these terms are overused and abused, and yet there's some truth to them, of course. In the old days, we would use tricyclic antidepressants because it dampened down their anxiety and had them have good sleep, and that seemed to help with the depression also. SSRIs have been helpful in this, and benzodiazepines and other anxiolytics, but that's dangerous, right? Because you're shifting one dependency for another, and so that's not a great idea. Phenothiazines and other dopamine blockers, I've always felt that was kind of punitive because it made people feel so crappy and empty-headed that it felt like punishment. And then lithium for depressed individuals. There are studies that say that it lessens alcohol abuse among aggressive and violent men. So there you go. All right, folks, let's take a 10-minute break. We'll get back together at the top of the hour.
Doctor, I'm going to run the attendance right now before people
Very
go.
good, Aiden.
Awesome.
Hey, ladies and gentlemen, are we ready to go? Can someone just say, hey? That's good enough. Thank you. Thanks. Okay, we have 2 hours, ladies and gentlemen, with a break in between. We are now shifting with our psychotropics for substance use disorders to hypnotic, anxiolytic, and sedative. These are the benzos and barbiturates. So there is a neuroadaptation that occurs. And is it a physiologic dependence or not? And it's something in between, meaning if we bombard our neurotransmitters with benzos or barbiturates for decades, like the LOL syndrome that I mentioned yesterday, we do produce physiologic dependence, but we also produce some neuroadaptation in a fundamental way, such as if you do go off these medications precipitously, and that might even mean in less than a year, that your neurotransmitters cannot adapt, and you wind up with some pretty bizarre symptoms that can result in psychosis and dementia looking. But it's a pseudo dementia. It's not a true dementia. In other words, it passes with time if something tragic hasn't happened, such as a withdrawal seizure, perhaps with status epilepticus, that results in anoxia and death. So it's important to diagnose and to treat it, and to understand the withdrawal syndromes that can occur. There are only 2 substances that can cause death directly in withdrawal. One of them is benzodiazepines, and the other is alcohol. And the reason for that is withdrawal seizures that could continue in such a way that they're continuous seizures, and you don't breathe, you don't take in oxygen, you have hypoxia, and you die. An opiate withdrawal won't cause that. It will just cause the worst flu times 10 you've ever experienced in your life, but that's not death. Or a stimulant withdrawal, such as cocaine or methamphetamine, where you may be plunged into days and days of sleep because you've been spending days and weeks of insomnia and an overactivated brain. That's not going to kill you per se. One of my fellow residents way back when had a patient, a young man, who died of suicide after she persuaded him to give up methamphetamine. Nobody was at fault. Nobody was to blame. But it's a good life lesson that these folks need to be monitored very closely in their withdrawal, even if they're not having a so-called physiologic withdrawal that medications could be helpful with. And then we talked about post-withdrawal treatment. And I mentioned to you my case of at the time we finished, in his early 80s, fellow, took me 18 months to get him off his Xanax, 8 to 10 milligrams a day. So how do you do these withdrawal syndromes with the benzos or barbiturates? You slowly decrease the dose, like I've talked about. Do you want to do it the American, pull yourself up by the bootstraps method, 10% a day? For 10 days, the British method, which is about 10% a week for 10 weeks, or what I think is a more sensible one is individualized approach that may take up to a year or 2. I'm not kidding. Takes that long for the brain to readjust, to neuroadapt back, to not need the substance. This is more than treating a physiologic dependence. It is having the brain restructure itself, and hopefully not so abruptly and painfully that they experience bad withdrawal symptoms. So you could substitute a long-acting, this is standard stuff, you could substitute a barbiturate, such as a long-acting one like phenobarbital, and gradually withdraw the benzodiazepine, but more quickly, even over a week or two, if you load them with phenobarbital, because there's two advantages to that. One is phenobarbital is an anti-seizure. It's a barbiturate, but it's also an anti-seizure medication. It was standard anti-seizure treatment before all these newfangled anti-seizure medications came along. So you will keep that individual from seizing and protect them from that, and you can withdraw their benzo much more quickly, like a week or two, if you load them up with phenobarbital. I don't like that, but friends of mine do it all the time. Just a little bit too cowboy for my taste, and frankly, a little bit too old-fashioned for my taste. And then you've got to wean them off the barbiturate and do that slowly. So to me, you're just adding a problem in a way, but you're protecting them, keeping them from seizing, keeping them from dying. That's valuable and useful, and it's a standard way of doing it. By the way, there's another standard method, speaking of alcohol withdrawal, that they used to do in treatment centers is they'd find out what your level of drinking was. They'd replace it with vodka and orange juice at that dosage, and they'd slowly withdraw you over several weeks, and they'd use more orange juice and less vodka in a very controlled way. I don't like that way either, but it was a standard treatment. I don't think it's in favor anymore. I haven't heard of anybody that I'm in contact with that still endorses that, but it was a quite established treatment back then. Replace their alcohol, their hard liquor, their beer with vodka, and then slowly taper them off in a similar manner to the phenobarbital with benzos. You could substitute a long-acting benzo. This is standard stuff. Librium is probably the best, and Librium tapers. So you're substituting a shorter acting, such as Ativan or Xanax or Cerex, with a longer acting one, and then slowly withdrawing from the longer acting one. That's actually quite safe, and I kind of like it because it's quite established, and you're not shifting medication classes to the barbiturates. You're just taking the amount of benzo they're taking, that's usually more short acting, medium acting, to a long acting, and then slowly tapering that. So that's the stabilization phase where you substitute one for the other, usually a long-acting like phenobarbital or Librium or Valium. Valium's a good one too. Librium was there first and kind of got established in detox protocols quicker than Valium did, but both work just fine. And then there's that withdrawal phase that you have to carefully manage. Okay, next slide, 168. We talked a little bit before about this post-withdrawal treatment and psychotropics for it. So what are you doing here? You're treating an underlying disorder. You're getting a lot of family history, and what were you like before you became an alcoholic? What were you like in high school and college when you were just a binge drinker and not a daily drinker of alcohol? What were you like before you started drinking a bottle of vodka a day for the past 10 years? I was depressed. I was anxious. I was panicky. I had to have a drink in order to get the wherewithal to go to work and 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 um, be calm. Oh, let's talk about your family. Yes, my dad was in Vietnam and he came home with PTSD, and he always has been on the anxious, sensitive side. My mom had panic symptoms at times. My brother went into the college student health center claiming he was having a heart attack when actually it was a panic attack. This is all very useful information to decide, I think I might try prescribing a SSRI for anxiety and for depression. I think I might try a tricyclic or tetracyclic antidepressant because it worked in the family for others, and there's a lot of insomnia, and this would help at bedtime, the sedation aspects of the tricyclics and tetracyclics. Make sure that person is not suicidal, because that overdose of tricyclic will cause heart block and death. Buspirone, Buspar, this was touted, came out about 20 years ago, was touted as the benzo replacement medication for mild to moderate anxiety that does not cause dependency or tolerance. And it's really true. And I've known a number of people, I've never been super impressed with it as a strong medication, but maybe I was harsh with that. And I know a number of people, patients and in my social circle, who are on Buspar and claim it's been very helpful with their ongoing anxiety. Not as good as benzos, but not with the drawbacks of benzos. And then there's good old cognitive behavioral treatment, which works better in the long run for anxiety disorders, right, than medication. So treat the underlying disorder, not necessarily with medication, but with good focused psychotherapy. Teach them self-hypnosis and relaxation training and skills. Send them to self-help groups and community and AA groups. Get them involved in doing things outside of their own comfort zone and world. Have them work at a zoo where they're cleaning up, elephant poop and stuff, helping the community, not as punishment, but as getting outside of their normal way of doing things and giving back to their community. Live the 12 steps, whether you're religious or not. There is some very helpful stuff in the 12-step programs. It also involves getting a sponsor, a caring mentor who has been through it more than you have and knows more tricks than you do, and will call you on your BS as they see it, and will be a great source of love and support to you. Will meet you for breakfast. I went to a murder trial 2 summers ago, and it was an acquaintance's son was accused of 35-year-old son was accused of murdering his girlfriend with a handgun when all forensic evidence pointed toward a suicide on her part. All the blood spatter evidence, the gun residue evidence. But unfortunately, he was a binge alcoholic. He was Hispanic, and it was a new judge, a new prosecutor, and it was a real book 'em Dano mentality. The county I live in California, is the 4th highest county for convictions per capita. Very conservative county. And I saw this young man being railroaded into what turned into a 50-year conviction. 25 years, but doubled because of the handgun. Now, why did I bring that up? Oh, because sitting in the audience or sitting in the visitors gallery was a man that I got to know over several weeks who was a family friend, AA buddy. And he told me once at lunch during a break, he said, I could have 50 people come tomorrow to support my friend who is trying to support his brother who's being accused of murder. And I tell me more about that. Well, we've been in AA together for decades. And although some of us relapse and some of us stray, we are all each other's best friends and support systems. And my buddy has, we have his back. And I'm just one of, I'm not even a friend of his. We don't socialize outside of AA meetings. I'm not his sponsor. I happen to be available, and I'm going to be there for my buddy just like he would be there for me if I needed that. I said, did he call you and ask? I was really curious. Did he call you and ask? No. I just knew the situation and I volunteered. I said, I'm coming unless you don't want me to come. And he said, yeah, I could use all the support I can. My brother's being railroaded and shafted. And I was very moved by that he could get 50 people to be there tomorrow if the call was made. And these were his AA buddies. So these self-help groups, and if you look at substance use disorders as a disease of loneliness and disconnection, then it makes sense that the self-help groups and a whole therapeutic community around you, supporting you, nudging you, nagging you, playing with you, arguing with you, being irritable with you, but watching your back can be life transforming if you have a substance use disorder. Very powerful stuff. These folks tend not to know how to self-regulate their emotions. They benefit from relaxation training. They benefit from meditation, from yoga, from Qigong and Tai Chi. They benefit from structured martial arts. They benefit from outside rules that are healthy and good rules of life type stuff. None of that has anything to do with medications. All right, question 41. SSRIs are the most commonly prescribed class of antidepressants in the treatment of substance dependence post-withdrawal affective disturbance. True or false? What do you think? Well, that's kind of a lob. It's true. And that's kind of the answer for everything, SSRIs, right? Relatively safe, relatively few side effects compared to the older ones. Tend not to die if you overdose unless you combine it with alcohol. Certainly true, the tricyclic antidepressants. And frequently used for post-withdrawal affective disturbance. Not habit forming, not dependency making, etc. Now let's shift gears to psychotropics for stimulant-related disorders. And by stimulants, I'm talking about methamphetamine primarily and cocaine. These are considered the stimulants. So take a look at this slide. Nearly 60% of addiction medicine physicians prescribe medication to help prevent relapse. And yet, there's no solid, how do I say this in a gentle way? It's really anecdotal. There's no need to put someone on a withdrawal medication protocol for cocaine or methamphetamine. The body doesn't require it. It mimics brain chemistry so exquisitely. That's why meth is such a scourge, because it mimics brain chemistry so exquisitely. It's like your brain, but on speed, on, most activated. 15 different medications are used from all different groups. It's really haphazard. It's really catch as catch can. There's no great overall rhyme or reason to it. And yet, why do prescribers prescribe medication for stimulant-related disorders? Because people are suffering miserably and they're exhibiting mood disturbance. They're suffering from depression, from anxiety, from insomnia and hypersomnia. They're miserable. So you want to throw some medicines at them to make them feel better. But there's not great research to support it. Nobody knows what's effective and what's not. And most of the research is on cocaine, which is very short acting, rather than methamphetamines or amphetamines, which are much longer acting. So, and there are waves. You know, cocaine was the drug of choice in the 80s with, what was it, Club 54 and disco dancing and bathhouses and et cetera, et cetera. Not so much anymore. Meth is really the drug of choice because it's cheaper. It's a longer high. You get more bang for your buck, right? Terrible scourge. All right. So how do we treat it? We can use substitution treatment, sort of analogous to methadone for opiates. And we'll talk about that. You could use an antagonist that blocks, like naltrexone for opiates. We'll talk about it. You could use a functional antagonist that reduces cravings. It's not a true antagonist. And you can alter their metabolism, increase the elimination, change the metabolites, analogous to antabuse. Makes you kind of sick when you use it. So what have we got for these disorders? We have antidepressants. They're the most widely used, the best studied, and the theory is that
You just sang?
Hey, Carmen, can you mute?
I'm sorry.
That's all right. Thank you. So the theory about antidepressants for stimulants is that cocaine addicts are depressed and they are self-medicating with their cocaine to pull themselves out of their depression. And so why not use an antidepressant, right? Especially a noradrenergic antidepressant, not a serotonergic, but one that mimics more the amphetamine itself or the cocaine itself, the stimulant itself. So use dizipramine. But my gosh, these studies were only up to 6 weeks long, and you have to really worry about cardiotoxicity if they relapse and they're still taking the antidepressant. Can you imagine offing somebody with heart failure, heart collapse, because they are taking this tetracyclic antidepressant, which is potentially cardiotoxic, and then they go on a cocaine bender? Well, one of my cousins died of cardiomyopathy in his late 20s because he was a cocaine addict, and he caused his heart to become dysfunctional, arrhythmias, and it's as though he had congestive heart failure in his late 20s, and he died. He would be in his late 60s now, one of my cousins. So when you think of stimulants and deaths, think of cardiomyopathy. You could use SSRIs. They decrease behavioral effects in animal studies, but in double-blind human studies, it doesn't show much benefit. You could use monoamine oxidase inhibitors. that increase the brain levels of biogenic amine neurotransmitters like norepinephrine. But you've got to worry about dietary restriction, potentially life-threatening increased blood pressure. You have to be really careful about that. And what if you went on a bender? You'd off yourself. Theoretically, Wellbutrin should work. It increases dopamine, but they don't see much effect in double-blind controlled studies. So it's pretty vague. Dopamine agonists, such as bromocriptine, amantadine. This is based on the dopamine depletion hypothesis and it decreases cocaine self-administration in rats if you give them a dopamine agonist. It decreases cravings in inpatient, but they've done double-blind outpatient studies and they're inconclusive. You could use stimulants analogous to methadone for opiates. Yeah, you'd be reducing craving and use. It's less medically risky. There's no contaminants. It's prescribed, Ritalin, methamphetamine prescribed, etc. You know you're not getting any fillers or fentanyl put into it or, cut with anything. But again, it tends not to work in double-blind controlled studies. It actually may increase cocaine addiction. Now, here's this nice study done in Lima, Peru, where the people chew cocoa leaves. And that seems to help people get off cocaine, to chew cocoa leaves. That's a substitution. And modafinil, Provigil, seems to show some benefit, but there are no good studies to verify that. So finally, we have neuroleptics. They don't really reduce cravings, but they could, and they can increase the chance of neuroleptic malignant syndrome. And do you know that a lot of people with the diagnosis of paranoid schizophrenia abuse cocaine? I'm not sure why that is, but it livens them up. It makes them feel more connected to the world because the neuroleptics can dampen down feelings and emotions, and you might want to counteract that with a cocaine binge or two. You could use anticonvulsants. That sort of blocks kindling, but the research doesn't back it up. I mean, theoretically, it seems to make sense. You could use amino acids, L-tyrosine, L-tryptophan. Studies don't show much benefit. You could try lithium. That seems to be logical. But studies don't verify any benefit. You could use calcium channel blockers, diltiazem, nifedipine, but studies don't endorse it. So here we have 15 plus different medications used for stimulant-related disorders with no good science behind any of it, and not very hopeful. Okay, now you've got these combinations, speedballs, cocaine and opiates, a speedball. What do? Well, oftentimes, if someone is in a methadone clinic and they're doing speedballs, they have insufficient dose of methadone. The idea is not to kick them out of the methadone clinic because they have a dirty urine, so to speak, but to increase their methadone dose, saying, we're not treating you strongly enough, robustly enough. We need to increase your methadone dose. So the average methadone dose in the United States for opiate replacement is approximately 80 milligrams a day. And you need to bump it up to 100, perhaps 110 or 20 milligrams a day. And they will cease and do some good counseling with them and good group counseling and continue them on their methadone at the higher dose. And you will lower their speedball use, their use of stimulants and cocaine. All right. Buprenorphine or Subutex. That's another substitute for methadone. It seems a little kinder and gentler in general. You can get your Suboxone or Subutex from an outpatient prescriber in a strip mall that has upwards of 300 patients that they can see in their practice. Used to be 100, now it's up to 300, I believe. And this could be a godsend. You don't have to have the embarrassment or the stigma of being in line at that methadone clinic at 7 a.m. in the morning. And I visited many a methadone clinic in my travels in one of my medical director jobs, where I'd be waiting with them in line, having bring somebody a cup of coffee or, share a story with me. Tell me what it's like being on methadone. What's good, bad, and ugly about it. In West Virginia, in Ohio, Pennsylvania, and numerous other states. Fascinating. Southern California, there's a slew of methadone clinics in the Inland Empire, Compton, etc. I think methadone is a godsend for people. I have a relative who is on methadone for chronic pain. Actually, I have two relatives there that are on methadone for chronic pain. They've been on it. One's in his mid-50s, one is in his early 70s. They've both been on it for a couple decades. They occasionally talk with me as the doctor in the family. Should I get off it? It lowers it worsens my libido. It makes me feel gluggy and not the most bright. By the way, these are not the brightest bulbs in the box to start with. Good people, good, solid, salt of the earth people that have really had chronic pain issues. And God love them for staying on their methadone. I always recommend they stay on it and not try to switch to something fancy or get off it or withdraw from it. I said, how's your life going? How's your functioning? How's your relationship with your wife and your family? And they all say it's going great. I said, why would you rock the boat? I don't want to be on this stuff anymore. I get it. Who would want to? But overall, cost-benefit ratio, why would you mess things up? And I always pull them down from their wish. They see a program on methadone or a program on that, and you should be drug-free or you're not an upstanding citizen. Nonsense. Whatever works, whatever makes you functional the best. And both of these guys, especially the younger one, is doing amazing things otherwise that are helpful to the community and serving other people, and really a pillar. And everybody would be shocked that he's been taking methadone from a methadone clinic for 20 years. So stay on it. And if you're straying and using speedballs, increase the dose, don't decrease it. So did you know that cocaine and alcohol has a huge comorbidity? There are 90% of people who use cocaine also abuse alcohol. That's not true on the other side, that 90% of alcoholics abuse cocaine. But there's something about alcohol and cocaine that helps smooth the highs and the lows of the cocaine, because cocaine, is very short acting. We're talking 20 minutes, 30 minutes. And that's kind of a bummer. And wouldn't you want to be a little drunk or a little high with alcohol to manage that? I don't know, I'm making that up. But if I were cocaine dependent, I could sure see alcohol helping me through. So indirectly, why don't you offer these folks Antabuse or naltrexone with their combined cocaine and alcohol dependency, right? It'll help with the alcoholism. All right. Oh, by the way, I'll just go back to this just to mark it. The most effective therapeutic treatment, non-drug treatment, proven by numerous research studies through SAMHSA, substance abuse, blah, 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 of the government agency NIDA, the National Institute on Drug Abuse, NIDA, subset SAMHSA, has done a lot of studies on what therapeutic non-drug interventions work best with stimulant abuse, particularly methamphetamine. And the answer is intensive outpatient therapy over extended periods of time that is focused on methamphetamine. It seems to be the right Goldilocks approach. Just enough therapy, not too much, not dependency making, not turning them into hothouse flowers, keeping them in their home communities, keeping them struggling in their work or school, but having a strong program of approximately 3 hours, 3 times a week with like-minded, and also in 12-step, NA, Narcotics Anonymous, etc., seems to be the most helpful over the long run to beat a stimulant, particularly methamphetamine dependency. It reminds me of that book, Chasing the Scream, by Johann Hari that I've mentioned in the past. I think it's 2015. I was very impressed with this book. This is a book that talks about how addictive disorders tend to be disorders of loneliness and isolation. And so they did some studies with rats in the cage, and they did these normal rat studies where the rats could choose either water or cocaine-laced water, and the cages were the standard rat cages of nothing in them but wire and water, and these 2 water choices. And invariably, the rats would choose the cocaine water over the water. Okay, contrast that with the rats that were put in cages that had wheels in them, that had little jungles in them, that had other rats in them, that had, in other words, a more natural, congenial, convivial, social environment with lots of playthings and lots of stimulation and et cetera, et cetera. What do you think? Those rats preferred water over cocaine water. Huh. Maybe it is a disease of loneliness and isolation. Why do heroin addicts end up in shooting galleries in back alleys or opium dens, etc.? Perhaps they are joining a tribe of like-minded people where they're not put down or stigmatized or arrested or raped or beaten or stolen from. They are looking for addressing their loneliness, their isolation. Why did Vietnam soldiers, 1 in 5 abused heroin in Vietnam? 1 in 5, whether that meant continuously or just episodically or once, 1 in 5 Vietnam soldiers abused heroin. And when they came home, what do you think? Only 1 out of 100 of those 1 out of 5 continued on heroin, ended up in shooting galleries and homeless and derelict and all that. But 99 out of 100 of that 20% gave it up and went back to their normal lives with their families, their farms, their auto shops, their communities, their children, their grandparents, their friends. One can make a case that addictive disorders is a disease of loneliness at its core, with people self-medicating the core unacceptable human phenomenon of isolation and loneliness. Something to think about. All right. Let's talk about opiate-related disorders. We're talking heroin, fentanyl, OxyContin, oxycodone, Percocet, Duragesic, patches where you'll raid the hospital. Hospitals don't allow this anymore, but you could raid the garbage and pull out these used patches and scrape out the opiates from the patches. Hospitals caught on to that pretty quickly. So in acute withdrawal, it's the worst flu you've had in your life times 10, and you feel like you want to die, but you're not going to die. You have GI symptoms, nausea, vomiting, you're running out of both ends simultaneously, your blood pressure's going all over the chart, your heart rate's palpitating your chest, you have it's like you got the flu and your temperature rises, you can't sleep, you're anxious, you're dysphoric, you're miserable, your joints hurt, your skin hurts, everything hurts. Boy, go back to heroin, go back to that Percocet pill, and you have just settled all that down. It is so compelling not to go through withdrawal. This is why heroin addicts will say, I'd rather die than go through withdrawal, because I feel like I'm dying when I go through withdrawal, and I just can't do it. I don't have the strength to do it. So I'm going to stay on heroin, stay on street opiates. I'm going to shift from a high school kid who gets opiates for his knee injury and then heads into heroin in adulthood, and he's dead from fentanyl overdose at 22. We read about this stuff all the time, the opiate epidemic, and it's upwards of 50,000 people a year, I believe. It's just a total tragedy. So how do you get these folks off it? You substitute, you put them on methadone, and then you slowly pull them off methadone. You shift all the crappy opiates and adulterations and cut stuff done by the Mexican mafia and cartels, etc., to give you this really dirty street drug that you don't know what the hell you're getting. This is why people die with fentanyl overdoses. And you put them on methadone and decrease the methadone. You find the equivalent dose of the opiate methadone, and you slowly detox them from that. 20% daily, may last a week or two. You put them on a alpha agonist like Catapress, the blood pressure medicine, clonidine, and you help them with all the stuff at the top of the slide of their blood pressure going out of whack, their heart rate going, all of that is improved with Catapress, the blood pressure medicine. You smooth out the withdrawal. You could substitute, instead of methadone, you could use Suboxone or Subutex, which is the straight buprenorphine, which is closest to the methadone and the opiate, where naltrexone, if you take it other than how it's prescribed, it will nullify itself with the naltrexone. So if you inject it, and you crush up Suboxone and you inject it, the naltrexone nullifies the buprenorphine, and you get nothing. You get squatch. So it prevents, at least in theory, misusing. Subutex is also used for pregnant women. Methadone is recommended for pregnant women more than Subutex, but there just haven't been as many studies with Subutex. I've seen it used with pregnant women. It's quite safe, but you don't want to use naltrexone and buprenorphine, Suboxone with pregnant women. You could have a precipitous withdrawal and do damage to the developing fetus. So you stay away from naltrexone with developing fetuses. All right. Isn't this fun? It's a creepy subject, but a very important subject, and one that it behooves all of us to at least have some basics around, some familiarity. Opened up a whole world to me that I wasn't necessarily looking forward to. But I love these patients. These are survivors. My God, if you're a heroin addict or a methamphetamine addict and you keep it up, you're a survivor. I mean, think about your own life and then add to it something like an opiate dependence. My God, what a pain that would be. And if we could just get people directed towards community, towards that fleshed out rat cage, and community involvement, helping others, be reborn, and in a way to give service to others and get out of your own way. That's what a lot of people do. That's why 50% of addiction treatment treaters, including the docs, the clerks, the receptionists, the counselors, are all in recovery at various stages, and some crash and burn. It makes for a pretty wild environment in a methadone clinic when your head counselor goes out on a cocaine bender and then comes back a month later, chastened and even stronger in their resolve. It's pretty amazing. Okay, so why would you pick opiate maintenance over eliminating the opiate altogether? Well, for a younger person, a teenager, a young adult, you would try for abstinence. Why would you resign someone to lifetime of methadone or Suboxone or something like that? I don't think that's fair. And they don't want it. So you maybe they have had such a terrible time with such ups and downs and problems with the law and overdoses and near deaths with, being brought back with Narcan, etc., naloxone spray, etc., which is $100 a dose, by the way, if you bought it at CVS or Walgreens by prescription. You might talk that young person into, you know what, your life has just been a hell for too many years. I really urge you to go on opiate maintenance for the next year or two and how will you know you're done and ready to move on and be abstinent is when you're in school, when you have a steady job, when you're living with your parents and contributing rent, when you're not leeching off your family, when you are becoming an upstanding citizen, when you're going to meetings, when you have a sponsor, when you're leading a functional life for a sufficient period of time, then taper off the methadone or Suboxone. Otherwise, you're setting yourself up for another failure. Don't demand to be abstinent after you've had a lifestyle for the last 2 to 4 years of total dereliction and near-death experiences, and your friends' death and near-death experiences. It's a setup for failure. So I urge these young people, stay on the maintenance. I don't want to. I'm sick of it. Yes, you're sick of it. I'd be sick of it if I were you. But I'm just telling you the odds. And let's get you stable and on the right path and getting those life skills that you need to be a responsible person, connect you to your community, and then get you off the opiate replacement. Then there are the older ones that have been on methadone for decades that you say, stay on it for life. Don't mess with it. It's working for you. Yeah, you have a crappy libido. Yeah, you don't feel so great. But you know what? You're getting older and you wouldn't feel so great anyway. So don't, the grass is not necessarily greener on the other side of the fence. So go with, go with Revia, go with naltrexone, go with Vivitrol as an opiate antagonist if you want to be abstinent and want all the help. So you're not going to get an opiate buzz when you use. Vivitrol is, I think, wonderful for that, despite its marketing hype and its expense. Then there was this medication called LAM, L-A-M-M. I only throw that in there for historical reasons. It was great, but it caused a lot of heart abnormalities, and it's not safe. So it was taken off the market. And now we have the newer as in 15, 20 years, Suboxone, Zubsolv, sublingual daily dose. You can get it from your doctor's office, specialized doctor with the DEA X certificate. You have to take a special course and pass a test to be able to prescribe Suboxone in your outpatient office. It's quite wonderful and revolutionary. It tends not to be as sedating as methadone, although it's individual per patient. All right, ladies and gentlemen, I think we need to take our last break, and we'll start up at 1 minute after the hour and have our final hour finishing up a little bit on tobacco, then heading into Tourette's, cultural issues, and new medications. So we're on the home stretch. Take a break. Thank you. Okay, ladies and gentlemen, are we ready for our countdown final hour? Someone can give me the high sign that they can hear me and they possibly agree with me.
Yes.
Great. Thanks. By the way, there's a trick in giving lectures that some old mentor taught me a long time ago, that if you can end your final lecture 10 minutes early, everybody thinks you did a fabulous job teaching. If you end your lecture 10 minutes late, everybody's a little irritable. So we're going to try to finish 10 minutes early, and I hope I can pull that off. All right. We have one more slide on psychotropics related to, actually two, on substance use disorders, and a final question. And then we're going to move on to medical issues, Tourette's and others, which is pretty cool and fun. Okay. There is nothing like tobacco and smoking to get you addicted. There is nothing like the quick gradient that occurs with inhalation. Within 10 seconds, your neurotransmitters, your nicotine receptors in your brain are activated by that puff on that cigarette. That's why that morning cigarette, when you wake up, gives you a few IQ points, wakes you up, makes you feel more alert, more alive, and happier. Boy, what an addiction. What a thing to accomplish. So here we have, in our current society, an influx of vaping. And yes, it's causing deaths due to some vitamin E variant that adulterates the tobacco oil in the vapor, V-A-P-E-R, not O-R. And it's not only killing kids, it's addicting kids in ways that we've never seen before with regular cigarettes. The gradient of use and abuse of I think I saw a statistic that something like 50% of middle school kids have tried vaping at least once, and that's phenomenal. And here there was going to be a anti-flavor vaping legislation that had cruised through the bipartisan House and Senate. Get that in this current climate of polarization. And with Trump saying in September he was going to sign it, and then the tobacco industry started lobbying him, and now he's not so sure he wants to sign it. And he's holding back. He doesn't want to kill business. He wants us to have a free society of deciding what we want on our own. Well, that is very misguided in my humble opinion, because you hook the kids on flavored tobacco early and you've got a lifelong addict. There are some teenagers, studies have shown, that are so genetically susceptible to nicotine addiction that literally one cigarette will hook them for life. So the answer is don't ever start. And if you have started, shift to non-flavored nicotine and tobacco, which just doesn't feel as good, taste as good. And if you can shift them to getting off it altogether with the use of replacement stuff like nicotine replacement gum, lozenge, etc. The easiest way to avoid nicotine withdrawal is to take another puff. And it's so compelling. What is nicotine withdrawal? Dysphoria, insomnia, irritability, anxiety, poor concentration, your heart rate's low, you have an increased appetite, you gain weight. It really sucks. So just puff away. It is the most addictive substance over heroin. and any other because of the delivery vehicle, the very quick gradient of in your bloodstream and into the blood, through the blood-brain barrier. We need to use a harm reduction model. That seems to work the best, and that involves things like nicotine replacement therapy. There is nothing wrong with nicotine by itself. After all, we have nicotine receptors in our brain, just as we have cannabinoid receptors in our brain. Go figure. It's the delivery vehicle that is killing us and causing heart disease and hypertension and pulmonary disease, COPD, etc., high blood pressure, etc. So try to get people to go to nicotine replacement. Try every trick in the book with patches, nasal spray, inhalers, substituting a cigarette for a nicotine gum. Okay, you're a smoker. You smoke 10 cigarettes a day. How about substituting 5 of those cigarettes for a nicotine gum? And then more nicotine gum. I know some people who have been using nicotine gum for years who were lifelong smokers before. That is much safer than smoking. Yes, it may raise your blood pressure a little bit. Yes, it may raise your anxiety level a little bit, but it's nothing compared to the dangers of the delivery vehicle of smoking. Okay. So use your behavioral approaches, use your pharmacologic approaches, use every trick in the book for this most addictive substance. So question 42, best practice approaches in treating tobacco use disorder include nicotine replacement therapy and behavioral techniques. Or C, A and B. Well, that's kind of a lob, right? Everything works and nothing works if you don't do it. Don't give up. Try again. Every time you try to quit, you are putting a little notch in the belt of being able to quit. Maybe not this time, maybe not the 5th time, maybe not the 10th time, but maybe the 11th time. Never give up. All right. Shifting now to other disorders, including Tourette's. Won't spend too much time on this one. It's common, but you don't see much of it because Tourette's people, kids and adults, tend to fake it a lot. And you may be aware of how people with Tourette's often have this triad, like 60% prevalence, have motor or vocal tics, they have ADHD, and they have OCD, obsessive compulsive disorder symptoms. I have worked with a couple of Tourette's patients. They tend to be on the bright intellectual side. They tend to try to fool you with mannerisms, such as their hand will move up to touch their hair, but then they'll smooth their hair as though they're simply combing their hair or something. So there's a lot of covering that goes on with these very smart, anxious people that are on the hyper side. There are famous cantors that have Tourette's disorder. There are famous singers. There are very smart people with Tourette's disorder, and they're quirky, odd people that are very successful in many parts of life, including the tech industry, Silicon Valley, etc., that has a place for nerds and oddballs, and even great successes for some of them. So, question 43, stimulant medication may be indicated for the pharmacologic treatment of Tourette's disorder if prominent comorbid symptoms of ADHD, predominantly hyperactive impulsive type, are present. True or false? What do you think, folks? I want to pin you down, but I have to tell you this is a trick question. My first answer is false, and that's the standard answer, that if you give a child, an adolescent usually with Tourette's disorder, a stimulant, and they have prominent features of ADHD, the old thinking, perhaps even the new thinking, is that you're going to make their tics worse, and it ain't necessarily so. So here's the way to do it, is try a 5 milligram trial of Ritalin with that Tourette's kid, and you say to the parent and the kid, this may make your tics worse. It may not affect your tics at all. It probably won't make them any better, but it may make your ADHD symptoms much better, and that may actually lessen your tics in intensity because you're not so hyper, right, and impulsive, which seem to go hand in hand with tics. So the jury's out, and it is a trick question. I used to ask this question in the final exam, but I took it out and threw it in here because it could be either answer. Do you see what I mean? And the way to find out, if you're curious and you really want to go with this, is to try it. One dose. Say to the parent, I am not creating a tic disorder by doing this. If I unmask more tics, it's temporary, it's not permanent. It's the length of time the kid's on Ritalin, which is 3 to 5 hours. Are you willing to take a chance of 3 to 5 hours to see if a stimulant medication can make a significant difference in your life? Because after all, one might speculate that it's easier to live and function with tics than it is to live and function with ADHD, with all its hyperactivity and impulsivity. So I might be inclined to try it. I haven't been faced with this situation, but I'm giving you the theoretical about it, and that there's no easy answer. So here's what people do with Tourette's disorder. The drug of choice is Haldol, the antipsychotic, not ORAP or Pimozide, because it can cause liver dysfunction. I've never used it, but it's always been touted as the drug of choice for Tourette's disorder. Or you could use an atypical antipsychotic. Well, I have evidence from my private practice that Risperdal tends not to work, tends to be too weak, because Tourette's is powerful. Those tics are powerful. And so I had one patient who had autism spectrum and Tourette's disorder. His dad was ticking away in my office when we had family meetings, and his dad is hyperactive. And so it chip off the old block. And this kid that I started seeing when he was 15, and I stopped seeing him in his early 30s, like 33, he came to our hospital at 15 when he had this terrible habit, very dangerous, of jumping out of the passenger door of the car, compulsively racing across the street to touch a tree on the other side of the street, and then racing back through traffic in downtown San Francisco with one-way streets that were streaming down cars, terrified the family. They almost got in car wrecks over this, and they hospitalized him saying, this can't continue. Well, a little Haldol, 2 milligrams, made all the difference in the world. Also, Anafranil, 150 milligrams at bedtime. It cut down the tics and the obsessive rituals, dangerous rituals, by 90%. I thought, wouldn't it be nice to try Risperdal and see if it worked over Haldol? Less of a chance of tardive dyskinesia, lifetime risk, blah, blah, blah. It didn't work. He went right back to his obsessive, compulsive ways and his weirdness and his tics, and back on Haldol and the Anafranil. You could also use Catapress, knock down their sympathetic nervous system a little bit. There's logic in that. You could also use Strattera, the failed antidepressant medication used for ADHD. There's logic in that. But Haldol was the trick, I'll tell you. Okay, medical disorders. Shifting gears totally. Here you go, folks. 13% of U.S. children, most have medical illnesses, chronic medical illnesses. Most are minor asthma, hearing or vision impairment. Okay, but a lot are serious medical illnesses, juvenile diabetes, cancer, heart disease as a child, etc. Here's some statistics, if you will, on moderate to severe asthma, vision impairment, hearing impairment in our society, heart disease, usually due to heart valve malformations in utero, etc., and juvenile diabetes. The amount of stress that this causes the kid, the parent, the family, and coping with this, the sibling rivalry, the shift in the family to the sick patient and sick sibling changes the whole family dynamic over time. And it's not unusual for the siblings to become caregivers and helpers of others, perhaps sacrifice their own futures and aspirations to do so. Okay, I'm just thinking about some of my own history. There's something in there. I was always going to go into business, but I'm glad I did what I did. All right. Other medical disorders. Look at pain syndromes, cancer, chronic pain. I had a wonderful acquaintance named Lucy Greeley, like in Horace Greeley. She wrote a book in 1995 or 1997 called Autobiography of a Face. This is her memoir of being diagnosed at age 9 with a cancer called Ewing, E-W-I-N-G, sarcoma of the jaw. Over the next 26 years, so we're talking until age 35, she had 30 plus operations for her Ewing sarcoma that kept growing back. She had ribs taken out to replace her jaw, and that would get resorbed by the sarcoma. She had plastic surgery and skin transplants, etc., that all got resorbed, leaving her in her late 30s with 3/4 of a face. From her jaw down, her mouth down, there wasn't much there, and she sometimes had trouble swallowing and eating, etc. Over the years, so this was, she came to a conference that I invited her to, a child psychiatry conference, a literary conference, and she spoke about her life experience, and it was mesmerizing. Can you imagine going into major surgery approximately every 9 months, starting at age 9 until you're 35 years old? Well, she got hooked on opiates that were started, of course, for pain after the operations. And she died of an overdose in her late 30s. She was 38 or 39. I met her when she was 35. Tragic. No one knew if it was an intentional overdose or an accidental overdose. It probably was an accidental overdose, but nobody knows for sure, and we'll never know. What a story. And what a book, Autobiography of a Face. By the way, one of the things that sort of saved her socially as a teenager were horses. Horses didn't judge her. Horses didn't make fun of her. She became a horsewoman, and with great skill, and it kind of kept her going psychologically. It was a wonderful, it's kind of my equivalent of martial arts for hyperkinetic kids. Wonderful person from New York City. So medications used for adolescents and children with chronic disease are often antidepressants, anti-anxiety meds. Whether they started out anxious and depressed, they ended up that way through all their medical problems and complications. Now, medications, these mental health medications, also have significant side effects: drowsiness, listlessness, disinhibition. Now, I'm not talking, excuse me, I'm talking about the medical meds, the opiates, the painkillers that they're on. They make them drowsy and listless. They disinhibit you. These folks are routinely put on opiates and benzos and antidepressants in the hospital to help manage their behavioral symptoms, if you will. It's quite something. Okay. Pain syndromes, we've talked about that a little bit. You may want to try a tricyclic antidepressant. You may, if they're so listless and out of it with their pain meds, etc., that you may want to juice them up a little bit with stimulants. They may have a seizure disorder and asthma, and there's nothing more frightening than having a seizure disorder, a chronic seizure disorder. When's it going to hit again? Could hit any moment. Oh my God, anticipatory anxiety, PTSD. You're going to be a recluse. You're not going to want to go out, because what if you start drooling or having that complex partial seizure, or God forbid, have a grand mal seizure in the supermarket like you did a week ago? It's going to make you a recluse, and you're going to be anxious and depressed. And if you go on meds, like antidepressants that juice up the brain a little bit, it might make the seizure activity worse. So, you know, this is shark-infested territory here, and it deserves strong interventions and a lot of kindness and a lot of going back and trying to figure it out again. One of my best friends in San Francisco was an LCSW who just happenstance was called to see a patient on an oncology unit, an adult patient, and before she knew it, her entire practice was devoted to care of people with cancer, either death and dying or helping them through their hospitalizations. And she developed a little niche for herself that she did for 15 years that was quite amazing. And cancer survivors, and she was an expert on death and dying and helping the family with this, and it was very meaningful and quite wonderful. Thank God she was there for some of these folks that were feeling alone and traumatized by their cancer, their chronic illnesses. So people with seizure disorders have a comorbidity of 37% with anxiety and or mood disorders. People with asthma have a 28% comorbidity with anxiety or mood disorders. If you have a traumatic brain injury, you're going to have a mood disorder, probably. You may have intermittent explosive disorder. You may have sleep disorder and insomnia. And SSRIs are kind of the drugs of choice for traumatic brain injury and PTSD too. All right. Other medical conditions that mimic mental health disorders. This is a really cool slide, in my opinion. So anemia, low, white and red blood cells have you feel washed out, listless, withdrawn, and depressed. They look depressed. Check a complete blood count. Do a thorough metabolic workup and a complete physical exam and an EKG. That depression may be anemia. It might be hypoglycemia. Hypoglycemics are generally irritable. They're on the edge before they pass out. they're not dealing with reality properly. Hyper or hypothyroidism, a mood disorder. They can look depressed or they can look manic. Check their thyroid. Have they been on lithium? They may have blown out their thyroid, or partially they need to have thyroid replacement with Synthroid. Mitral valve prolapse is classic for anxiety and panic attacks. Has it been checked out? Someone has panic disorder as a child, check out mitral valve prolapse. Surely it's been found, but maybe it's low level, and maybe it was small before and not too profound, and now it's gotten worse as they age and their heart changes shape and their valves stretch a little bit, blah, blah, blah. A mitral valve prolapse at age 5 may not look like a mitral valve prolapse at age 15. Sleep apnea. You're going to have chronic anxiety and depression if you are underslept and in chronic insomnia and choking and things like that in your sleep apnea. How big is the kid? How heavy is the kid? Does the kid snore? Does their siblings say, Johnny snores too loudly, I have to put a pillow over my ear to go to sleep? That's sleep apnea until proven otherwise. Get it checked out. Cancer, anxiety and depression. Liver failure. I just learned of a friend during the break who's dying right now of liver failure. And he's very depressed and he's getting delirious, showing signs of dementia, and he's being moved to hospice. It's very sad. In his early 60s. Encephalitis will cause depression and delirium. And we see, you know how they do these ads on TV? They hype it with the meningococcal vaccine that you get before you go off to college. It could happen to your child. That's encephalitis. And it could be deadly, and it can also cause depression and delirium. Pure porphyria, this was the King George III thing of abdominal pain and psychosis, Mad King George. This was during the US Revolutionary War. So if anybody has psychosis and stomach pain, abdominal pain, rule out porphyria, which is a blood disorder. Okay. So there is a strong role for clinical psychologists in healthcare, consulting with behavioral and mental health issues on medical wards. It's a valuable service and highly respected. And you get good referrals to your outpatient practice, by the way, as a result. And you're very helpful to that family and that individual when maybe nobody else has been so helpful. Okay, non-traditional treatments. This is kind of fun. Secretin. So there was this doctor back in 1998 that had 3 children who were autistic and also had pancreatic disease, exocrine pancreatic insufficiency, which means that they could not produce sufficient digestive enzymes to digest proteins, fats, carbohydrates. And he gave them secretin, a pancreatic enzyme that treated their pancreatic insufficiency. And woe and behold, these 3 autistic kids got better with their autism. So, hey, secretin, pancreatic enzyme for autism treatment. Well, it's anecdotal. It hasn't able to ever be reproduced. And it seems to be nonsense. But it's taken off and run with it because everybody's desperate for a solution to autism, a cure for autism. But it seems to be nonsense and not reproducible. So this is interesting. There's a study done in 2002 with a subtype of pervasive developmental disorder that also the kids had chronic diarrhea. And so secretin improved their chronic diarrhea, it improved their mood, it decreased their hyperactivity, and 70% of the parents swore by it and continued using it even though it was debunked. In other words, they latched onto it. They said, it's helping my kid, and I'm going to continue hell or high water. Remember that all medications tend to have a 30% placebo effect. Right or wrong, that's just reality. St. John's wort came out a dozen or more years ago as the be-all and end-all of non-prescription serotonin antidepressant, a homeopathic, a holistic, and organic treatment for depression using St. John's wort, W-O-R-T. Well, they've and it actually appears to be helpful for mild to moderate depression. But good rigorous studies have not borne out usefulness. And so there you go. There is a natural antidepressant, quote it natural, that's Deprex. It's a dietary supplement with nutritional support for moderate to severe clinical depression. And it treats possible mood imbalances, melancholia, extended periods of simple sadness and grief for those going through a period of disappointment or rejection. It has the dietary precursors to different neurotransmitters such as serotonin. It seems, which serotonin plays a crucial role, of course, in mood regulation and depression in the emotional center of the brain. By the way, I'm reading this from Anecdotal Stuff. And it's one of the select homeopathic medicines that help to naturally regulate and balance neurotransmitter production and activity. And it seems to be poppycock. There's no studies that verify that it's actually helpful except in anecdotal reports. But hey, it's organic, it's homeopathic, it's not made by those wicked drug companies, but it may just be placebo. And there are no studies, certainly no double-blind controlled studies that verify effectiveness. Okay. And then finally, there's diet. Okay, so hyperactive kids, and you give less sugar to a kid, they're going to be less hyped up, right? So ergo, low sugar is a treatment for hyperactivity. One of my good friends that I still stay in touch with on Facebook, and I worked together 30 plus years ago. She was the head special ed teacher at my hospital, and I was the medical director. And her master's thesis was just on this subject of low sugar diets and ADHD. And even back then, she said there's no scientific evidence to show that a low sugar diet. Yes, if you give less sugar to a hyper kid, they might be a little less hyper, but you do that with a regular kid. And it's just good sense not to load kids up on
If you can hear us, we don't have sound.
Yeah, Dr. Brady, did your microphone or your they come unplugged?
I cannot hear any noise from Dr. either. I might just give it a call.
goodness. You know I'm in the middle of my lecture. Oh, shit. So what do I do?
We
seems
got
to
you
be
back
working
now.
in
We
It
can
looks
hear
like
you.
we have
Working
sound
well.
again.
We can hear you now.
What do I do?
Hey, we have you now. You can
I
just
haven't
talk to
done
us again.
anything differently.
We
We
lost
can hear you.
It says I am talking, and the little green thing on the microphone is going up and down.
We can hear you now.
Well, okay, I don't know what else to do.
Dr. Brady, we can hear you now.
And let people know that I see I don't understand, and
I don't
I'm
think you can hear
sorry. And
us.
if we lose it, it's only 10 minutes of the final lecture, and they should just go through the slides. I'm sorry about that. I hate this program. I hate this kind of action, but there it is. Okay. Okay, thanks. Okay, so I understand you can't hear me anymore, and this kind of
We can hear you now.
We can hear you now.
I can hear you now, Doctor. Now I can hear you.
really tired of techno stuff. Can anyone hear me? Damn.
Can't hear you, Doctor. Can't hear you.
I can hear you, Doctor.
I don't think he can hear us though. So us talking isn't helping.
Doctor, we can hear you.
Hello, can you
We
hear
hear you,
me?
Doctor. Yes, we hear you.
Okay.
Doctor, we can hear your voice. Hello?
Aiden, he can't hear you. You're gonna have to call him again and tell him.
Hello?
We can hear you, Doctor.
Aiden, he can't hear you. You'll have to call him.
Okay, I'm gonna call him again.
What's that? Say it again. You can.
Yes, in the class I could hear you.
Okay, so I should continue?
Yes, let me again go back. You were asking if anyone could hear you, and me and the student were responding, but I don't know if you can hear us, that we can hear you.
I don't think I can hear you guys. Okay. Well, Aiden, I just chopped off my phone with you. I'm sorry. I have just a few minutes. If people can hear me and you said you could, then I'm going to continue and try to finish in 10 minutes. And that means that students apparently won't be able to share anything with me. But if you can hear me, what I'd like you to do, I apologize for this. This really irritates me, but I'm sorry this happened. And we'll try to figure out how to not have it happen for you guys again. And my only suggestion is to finish looking at the slides. Great, you hear me, thank you. If you lose me, just finish looking at the slides and I think you'll get something out of it. We're nearly done. We're so close. So I'm going to continue on and hope that we can, you guys can hear me enough. Okay, so we were on slide 192, And sugar is not going to help in any real way with ADHD. Okay, so here we go. We're looking at non-traditional supplements, non-traditional treatments such as nutritional supplements, megavitamins, minerals to treat schizophrenia. There's simply no evidence in controlled studies. However, anecdotal reports say that megavitamins and nutritional supplements decrease cravings for alcohol and drugs. My supposition is that people are metabolically unstable or malnourished to some degree, substituting alcohol for food, and that this would help them with nutritional supplements. Neurofeedback EEG, training the brain with EEG attached to a computer monitor. People swear by this. I have personally been unimpressed. I have heard anecdotal reports from colleagues who have had it done, and I've read research that said that it really helps, and insurance companies are paying for it, so I will leave it at that. Transcranial magnetic resonance, which is sort of like ECT light, where you put a football-like helmet with the powerful magnetic waves, etc. Also vagal nerve stimulation can be helpful, but I've never heard these used on teenagers. I've certainly heard it being used in experimental, but also TMR, transcranial magnetic resonance, is being increasingly used and paid for by insurance companies. Occupational therapy, and by that I mean to learn socialized behavior, applied behavioral analysis, begun by Victor Lovas, PhD, and by Stanley Green, MD, of floor time play therapy, can be quite helpful and called occupational therapy. Now, shifting to cultural, gender, and socioeconomic factors, it's really important to know where that individual kid and their family stand in terms of their notions of mental illness, particularly if they come from a culture different from your own. If they're an immigrant, they often are a survivor. They often have PTSD. They often had pre-morbid conditions that pre-existed their immigrant status. And different treatment approaches are required. So PTSD may be manifest as anxiety, depression, substance use, psychosomatic illness, eating disorders. It's really important to understand the culture of origin and their ideas about mental illness and where they fit in or don't fit in. So some of these treatments speak to rebalancing of your yin and yang, of your humors, of your life forces need to be rebalanced. Is there a respect or a rejection of Western medicine? How do they understand side effects and how to explain potential side effects? Blending of cultures. Often there's a wish to blend. I had a wonderful case of a Taiwanese off the boat, so to speak, young woman whose family insisted on bringing in the Christian minister to do an exorcism in the hospital because she was psychotic and depressed. Well, they accepted medication, antipsychotic medication, atypical antipsychotics, and depression medicine. And I accepted the exorcism, even watched it in the hospital room and was fascinated by it. And she got a lot better. Was it because of the exorcism? Was it because of the medications? Was it because of the mutual respect? I don't know. But we were open to it, anything that worked. Gender. Gender is a big deal. Males tend to have more disruptive disorders. Females tend to have more internalizing disorders, although these are stereotypes. And medication differences may occur because of different body size, different metabolism. For example, females tend to object more than males to side effects such as weight gain or hair loss. In terms of side effects above, as I mentioned, non-whites tend to experience more side effects, especially with antipsychotics. Remember the placebo effect. They may say, Western medicine, that's the best. You've just given them 20 to 30% gain by the placebo effect. Let's shift gears briefly to the hearing impaired. Now, the hearing impaired, whether they're full deaf, partially deaf, whether they come from genetics with deaf parents, or hearing parents, the vast majority of hearing impaired kids have hearing parents. Often these parents only learn kitchen sign, not full robust American Sign Language, such that their inner life is restricted because they don't have the depth of communication with their parents that they would otherwise have with a full-on hearing impaired parents who take it as natural and normal to be hearing impaired because it's gone through generations. It even comes up in controversy with cochlear implants and oftentimes it's controversial with hearing impaired parents to have their hearing impaired child being offered a cochlear implant. It changes the whole family dynamic. It changes that kid to be more of a parent and more parentified than they would otherwise be. It infantilizes in some way the parents. So it's controversial and it needs to be tread with very carefully and sensitively. And there's no right or wrong answer about cochlear implants. If you are hearing impaired, you have relative sensory deprivation and you're more prone to voices and paranoia, narcissism, self-involvement. And what if you have coexisting mental health issues of paranoid schizophrenia, of bipolar? Just being hearing impaired doesn't protect you against any of the mental illnesses, right? So that's an issue. If it's due to illness like measles, in utero infection, etc., you may have other mental problems such as ADHD, remember minimal brain dysfunction, behavioral disorders, etc. So it really requires a thorough evaluation. You really have to work hard at true informed consent. And are you aware that an average hearing impaired person reads at a 4th grade reading level as an adult? That really makes them different than others, separate from their hearing impairment. Okay, we are going to finish, and I was going to give you 10 minutes, but we got tripped up a little bit, but I'm not going to go into this in too much detail. These are just the medicines to keep aware of that are newly released and are being used for children and adolescents without FDA approval. They're off-label use, if you will. And here's a list of them. My 17-year-old nephew has already been tried on Abilify, Fanapt, Safras, Latuda, and he's now on Vraylar. And so they're being used for kids, and it behooves us to learn everything we can about them. Here's some of the other new ones that are just out. Prestique, Vibrid, Vetsima we've talked about, Brentalex, a new transdermal patch for ADHD, Intermezzo, isn't that cool? Zolpidem for insomnia. And finally, future research. We're looking at the glutamate system. We're looking at genetics. We're looking at the possibility of chronic inflammation and oxidation problems in the brain that cause mental illness and how to reduce inflammation, if indeed that's real. So we need to establish large registries to assess long-term safety in naturalistic settings. And here are some new clinical trials that are coming down the pike using the glutamate system for depression and also schizophrenia. Now we're talking about dopamine D3 receptor medications, and let's look at the cannabinoids. Ladies and gentlemen, we are finished. You did it, I did it, we did it. I want to thank you for your attention, your interest. It keeps me going and it keeps me on top of this. I thoroughly enjoyed it. It's a long weekend. I'm exhausted. I bet you are too, but I think we pulled it off. If you have any feedback for me, how to improve things, how to correct things, I invite you to get hold of me. My email address is tbradymd@pacbell.net. That's tbradymd@pacbell.net, the old Pacific Bell telephone. I thank you very much for your participation and attention, and let's say goodbye. Thank you.